Thank you, Christelle. I'm going to bring my slides up in a moment, but yeah, the TM is a trademark, by the way. But I also want to point out that when I first came into the mindfulness space way back in 2001, it might have been said then that it was unproven therapy. And indeed, I think many of our colleagues felt this was very soft medicine that was really just where they would send patients if they had run out of ideas. I know that when we started with telemedicine in Ontario, we were one of the biggest users, but I sensed that the telemedicine coordinators were glad for us to use their telemedicine because it was new at the time, but they sort of thought that it was softish medicine holding the door open for consultants to come later who would provide the real medicine. And that was my sense way back then. I indeed, when I went to train in mindfulness-based stress reduction with 𝐒𝐂𝐑𝐈𝐁𝐄 down in the States, was very skeptical and really didn't think that this was going to be of much use. And boy, was I wrong. So I'll bring up my share screen and share my slides with you. Hopefully you can all see that. And so as Christelle has introduced me, and by the way, thank you very much to the Pain Society of Alberta for inviting me back again. So my principal work in the last several years after I retired from doing conventional pain clinics using pharmacotherapy was to promote mindfulness, to train new facilitators in facilitation of the program that we had evolved back since 2002. So I've retained being an instructor at the University of Toronto School of Continuing Studies. I do occasional patient groups, but lately it's been more for veterans. And I want to say that if you want a copy of these slides, please email me at the email shown on this slide, and I'd be happy to send them. And also, please feel free to photograph any slides that you want to retain information from. The objectives would be that this presentation will enable you to describe the difference between authentic and popular belief about mindfulness practice. I do think that there is what we refer to as a sort of Mac mindfulness, the fast food of mindfulness, where some media has portrayed it as being just too simple. And that has led to some poor media coverage, some inappropriate media coverage that doesn't really understand what mindfulness is. I also want to help you locate recent reviews on its efficacy for clinical conditions, including pain, and to identify the importance of preamble, meditation delivery, and inquiry in mindfulness facilitation. I also want to say that I ran a company to promote professional training with the University of Toronto to collaborate with them. It was called Neuronova Center for Mindful Solutions, and I no longer own that company, so I'm declaring that as having given up that conflict of interest, because my way forward now is to hopefully establish a not-for-profit to promote mindfulness in healthcare, because I feel so passionate about it, and I'm surrounded by people that do too. So we'd like to make it more available across Canada. So I'm going to start by saying mindfulness, what is it? And it is an awareness that arises through paying attention on purpose in the present moment, suspending judgment. And that's one of the most important pieces, that non-judgmental paying attention and being aware of what's going on in this moment. And Jon Kabat-Zinn provided that definition. I don't think too many of us deviate from that. However, there's a lot of, variation in how people define meditation. Many different definitions. In my book, it is practicing what I just described as mindfulness for a defined period of time on a regular basis in order to maintain the skill of being able to live mindfully. So it is sitting quietly while directing attention in specific ways, but meditation can also be a movement meditation, so not always sitting. It is a skill, it is an experience, it's a formal exercise that we use to cultivate ongoing awareness and compassion. But when we teach the program of mindfulness, it's crucial to teach these attitudes and to have those participants that are going through that 12-week program with us, where they attend once a week for 2.5 hours, and they do sort of work at home and meditate daily and do some of the readings. It's important that they're also practicing suspending of judging as they see situations arise in their lives. It's important that they're bringing to each situation a beginner's mind that they didn't have before. They were always bringing preconceived ideas of what was going to happen. And that creates tension and can increase pain. So becoming an expert, if you like, becoming more practiced in beginner's mind, really reduced tension in the body and often improved relationships. It's cultivating patience, which not too many of us have, even less so, I think, lately with everything that's bombarding us. It's a letting go, such as of the need to be right, a letting go of having opinions ourselves that we won't let go of and we won't give space to others. It's practicing non-striving, such as of holding on to an outcome that we think is important. And in the letting go and the non-striving practice, sometimes we are able to encourage people to look at why they keep firing things on their resumes at this training, the next training, and so on. And in fact, letting go of the need to build up that and really just run with what we want to do and what our values lead us to do, as opposed to adding more stuff. It's also trusting in ourselves to be able to do this work. And the final one, acceptance, has been the most difficult thing for those living with chronic pain within our programs to practice as an attitude, until we reinforce the fact that acceptance is only of where we are in this moment. It doesn't mean that we're accepting that this is the only way we're ever going to be, but it also means that from acceptance of what's happening in this moment, of how we feel in this moment, it's a springboard to go forward more successfully. And cultivating these as healthcare professionals, as well as the patients and the people that go through our programs, but cultivating these attitudes, cultivating mindfulness as healthcare professionals, allows us to do better at providing person-centered care, which I think is more accurate than patient-centered care. What it is not is a tool to create a state of consistent calm, this state of Zen-related bliss that I think the media seem to think it is. It's not a cure for pain, anxiety, or depression, but it does help to reduce these if it is practiced consistently. It's not to create comfort in conventional meditation positions. We emphasize to those who are living with pain that they can meditate in any position and they can move during meditation. It's not a hypnotic state to achieve a predetermined goal either. We are not hypnotists when we practice mindfulness, but there is some overlap between hypnosis and meditation. And if you look at the literature on that, there is no defined definition of hypnosis that eliminates that it's a form of meditation, and vice versa. It is not, by the way, creating an empty mind. In fact, as people come into mindfulness practice with us, what we found back in 2002 when we were establishing the first programs in St. Michael's Hospital and later on at Sunnybrook was that we were seeing agitation arise. We were seeing flashbacks to previously, hidden memories. These memories were there, but they were not in patients' recall because they'd been buried. it did trigger buried trauma and memories, recall of trauma, and it did allow people to have insights into what had happened to them in past experiences that were affecting their behaviors now, and even playing into why they had so much pain and why they weren't healing. And at the beginning, those who are inexperienced at meditation and mindfulness, for many of them, it did increase pain because their minds were less busy and cluttered, and so they could see the pain more. But in addition, if they were in the process of a pain exacerbation, like I might be in the process of a migraine because I'm a migraineur, we did emphasize that wasn't the time to do meditation. So gradually we noted that the agitation and the flashbacks were part of their experience. And interestingly, when those came up in a safe environment that we created for them as well-trained facilitators, they could be worked upon, they could be processed at their own rate, and they could lead to more healing and to decreased pain and decreased suffering. And so what I saw slowly happening through those programs and through watching the participants of those programs after they left them and continued in alumni programs or just continued to meet with us, what I saw was a gradual integration of past traumas and an acquisition of more wholeness as a patient, as a person, as somebody who was actually more able to look after their own healthcare. And that really resonated when I saw the current work that's going on with the psychedelics, because I think that's a fast tracking of what we were doing in meditation work, and a more expensive form of it too, and less accessible than what we're able to provide now more simply. We therefore always assess the risk of harm such that those we put into our programs needed to have treated mental illness, not untreated mental illness, and they could not be in crisis to benefit from our programs either. So we did consider biopsychosocial assessments before including them in our programs if there were flags that weren't noted by those who were enrolling people. We also devised the MBCPM program to be more trauma sensitive and trauma informed, because the patients needed that. And so we were acquiring that insight. But we didn't even know the terms trauma sensitive, trauma informed back in those days. We instinctively began with shorter meditations. Movement practices really helped if flashbacks were occurring. The body scan was very triggering and really couldn't be used in the initial classes like it was traditionally in MBSR and MBCT. And very importantly, we needed to give a little warning to patients about the fact that meditation practices, as we were guiding them, might not always result in what they were hoping for, which was more tranquility and equanimity, but sometimes could agitate. And if we were able to do some warning and some ensuring they knew how long a meditation was going to last, giving permission for the positions that were comfortable, etc., then we were more likely to work with patients that were accepting of the entire program as they worked through it. We were able to ensure that those who didn't have a good experience in some meditations didn't hear others who did and think that they had failed. So it was really important to do that, to conduct the meditations in a practiced way, and post-practice to do inquiry at a gentle level, so that we weren't forcing people into their insights, but were gentling them into the insights that could be helpful and giving them permission to just dip their toe in the water. And very often they could gradually self-help and self-soothe and get the most out of these practices. Indeed, I would say that those who haven't been through mindfulness programs, if they are going into just a straight meditation lunch hour at work, the longer practices can actually bring up insights and agitation that really needs to be held by a skilled facilitator. So I generally recommend short practices if you're doing just a lunchtime sort of drop-in meditation practice. In addition, facilitators, we felt, must have a personal mindfulness practice that's very accepted, be well trained with a professional training that's not too cheap and sort of rapid, be mentored, hold the space competently, and emphasize the need for individual therapy for those participants for whom a lot has come up quickly and maybe they can't continue on with the program, or they need to go to a therapist before they can rejoin. And also, we need to, as facilitators, recognize when we shouldn't be advising to continue practice when those intensities arise, and we should be promoting the use of individual therapists at those times. So there was a lot to learn. And indeed, in the UK, they developed a mindfulness-based intervention teaching assessment criteria document, a big document that we flag to those who train with us, and has 6 domains that we aspire to achieve eventually as we experience facilitating and become more competent in providing these programs. And they also recognized, that group originated this, but they reached across the Atlantic with the authors. They also recognized that after a lot of evidence-based work had been done to show that mindfulness was very effective, that there will be many adaptations of mindfulness programs aimed at different populations. So they published recently on how, why, when to adapt, and what the explicit components need to be to still be called a mindfulness-based intervention. So not every program has to be tested by randomizing, because there are so many of them. So it became a shift in approach from biomedical, biomechanical models to biopsychosocial and spiritual models. And with mindfulness, the goal is not to eliminate pain and stress, but to teach us how to be self-aware and respond to stress and pain in constructive and collaborative ways. A different approach, an important approach. Indeed, meditators feel and sense pain differently. Our thresholds are increased, but that's because the sensation of pain is not accompanied by wind up in other centers of the brain that are the cognitive components. We basically suspend judging, and that allows a higher pain threshold. It's what reduces the extra layers of dread, worry, and stress, and does allow for less suffering and less pain suffering in particular, such that I can back this up a little bit with one of our performance indicators, of which we did several, but 34% of those coming through our programs during 1 year did acknowledge that they had reduced or eliminated their pain medications as a result of the program. Many books were also noted by participants as having elements of what we were teaching in them. And these are very easy to read books, wonderful books. Why Zebras Don't Get Ulcers, The Power of Now, The Mind-Body Prescription, When the Body Says No, and The Brain That Changes Itself. Many of these, of course, are healthcare professionals writing them with very good evidence base. There was an explosion of research from 2000, when I actually trained in mindfulness, up to current day, and so many articles now are evidence-based, and there was also a profusion of programs that were aimed at specific populations. This is a timeline slide where MBSR kicked it off, as it were. Marshall Lynham was very busy with dialectical behavioral therapy for those with borderline personality disorder. Siegel, Williams, and Teasdale reached across the Atlantic together to look at a very elegant study over a couple of years on mindfulness-based cognitive therapy that was randomized and very well done. We originated the mindfulness-based chronic pain management program to be trauma-sensitive and trauma-informed for our population. We published in 2008 and 2012, but also wrote a book that was more digestible for this population. And then ACT, which we didn't go to using, but is used in chronic pain work. We've heard of it already today. And then mindfulness self-compassion, which is now pretty widely understood as being another layer and very important. And Nancy Bardock also published a book called Mindful Birthing, and is very well known now in that space. just to give you some reviews that really are more up-to-date and demonstrate efficacy with very large N's as they looked at randomized controlled trials, broad efficacy of mindfulness interventions for all groups studied, including physical illness, mental illness, and generally healthy participants. Another large study, which was 12,000 participants, 142 randomized clinical trials, and follow-up showed that mindfulness interventions were equivalent to evidence-based treatments and superior to usual care and other treatments. The most consistent evidence for mindfulness-based interventions was seen in depression, pain, smoking, and addictions. And a study that I particularly like, which is looking at chronic low back pain, this was a study that looked at cost as well and showed that CBT and MBSR were pretty equivalent in improving the quality of life for patients, and that MBSR and to a lesser extent CBT may provide cost-effective treatment for chronic low back pain for payers and society. Quality of life years definitely justified, the cost of that justified mindfulness inclusion in all interventions for pain, in my opinion. So I want us to pause for a moment and just take a moment here to either shut our eyes or close them. We're just going to be doing this for a minute. And to think about what we are doing right now, just to become aware of that, as opposed to thinking about it just to raise our awareness. Can we move our attention right now to the surfaces that are supporting us and how they feel? And that they're connecting us with others in the same space or across internet. Can we bring our attention to our breath right now? Or if that isn't comfortable, another focus, such as the tip of our finger or something in front of us. Just gazing at that with our eyes open perhaps, but slightly unfocused. Can we bring our awareness back to being in this moment, in this present moment? Not thinking of the future and not thinking of the past, right this moment. And what are our senses picking up for us right now? Our hearing, maybe our sense of smell, and our sense of touch. And then just moving our awareness back to the presentation. After the evidence base has been so accumulated on the efficacy of mindfulness that I believe should be offered widely and easily across our country, I believe there's a need for an advocacy role for mindfulness to be that available in medical practice in Canada, especially as we can now offer it on the internet, and the last 2 years have shown us we can offer it effectively through internet practice. We've done all our programs in the last couple of years through internet, and it has had a few challenges compared to in-person work, but it's worked well. The evidence base is now there. The cost effectiveness, potentially even cost saving, has been shown. But widespread implementation in Canada isn't here yet, and the UK is far ahead of us. They have a parliamentary setup where they are devising a framework. They have it throughout the NHS as well, and in education. It improves quality of life and compassion and resilience for healthcare professionals who practice it, as well as patients, and I believe the interaction will be better when healthcare professionals are more uniformly trained in various mindfulness-based interventions. But fee codes for facilitation by MDs in most of Canada don't exist. We have them in Ontario, but they've actually hamstrung us a little bit lately after the pandemic. ends, our fee codes won't be so permissive. They will still be there. And in Quebec, it can be done as well, but the cost or the payment to the MD is the same as for one-to-one therapy if they're doing group. So just the same as for seeing a single patient. And the funding is far too sparse to take programs from other healthcare professionals too, like psychologists and social workers, and insurance companies are not covering it for group work. So this needs to be tackled. There needs to be an advocacy organization, maybe called Mindfulness Canada, to ensure that resources are there on their website and that they can promote that mindfulness programs are more available. These are the books that were associated with the slide that I showed, that showed the various mindfulness interventions for different populations. And another slide to show you where there are openings for professional trainings, so you can access them both in the States but also in Canada. So I just want to allow you to sit with that slide for a moment. You can maybe photograph it, or if you want to ask me for the slides, you can have it to click on those links. And finally, there's my email again for a copy. And I want to thank you for being here with me in this moment and say how amazed I am that over the last 20 years, I've seen the mind-body connection work well, and how important it is to have compassion for our patients, to have time for our patients, and to help them to acquire these skills as we continue to acquire them too. Thank you very much.
I'll just take 2 questions. Right.
Hi, Jackie.
Thanks.
Thank you. It's always a pleasure to have you present at our conference, at our World Pain Summit. And I really especially liked what mindfulness is not. And it was especially timely with our previous conversation about health misinformation. So thank you for clearing that up. I think that's really important for us to note. In addition to your mention about how do we execute, how do we showcase mindfulness during the pandemic? And I'm going to dive into 2 questions for you. One of which lends itself nicely to the pandemic and how we can support people through that challenge, and kind of give your opinion on that. So we have someone who's asking, during the pandemic and the quick pivot to offering pain treatment virtually, what is your opinion on how effective the virtual delivery of mindfulness groups is compared to in-person groups?
Right. So prior to the pandemic and years ago, we actually offered mindfulness across Ontario through telemedicine. I did 50 sites through telemedicine, but the patients who were participating were in groups in their health centers to begin with. And so that lent itself very well to doing large groups, several groups in several health centers. And we did do the data on that, on quality of life, improvement in mental health, decrease in suffering, and decrease in pain. And it was as effective pretty much at the distant sites as it was at my own site, or if I was doing just in-person groups. We actually compared off-site groups where I had no in-person group and in-person groups there was no off-site group, and they did pretty much equally well. When we got to the pandemic, we had to do it into patients' homes. So that meant we could only do maybe groups of 15. We had to have stable internet. We often couldn't reach those in rural areas with poor internet connections. But we found, surprisingly, that we did very well, that the outcomes, and we always did evaluations, were very good indeed. And that meant we could extend our reach. We had already been training through the university certificate into other countries and other provinces. So we already knew we could use the internet for trainings, but we could also use them for clinical situations. One of the downsides is that a lot of patients have open plan living, and it's kind of hard for them to find a space where you can be confidential and where other participants feel safe that they're not being heard in another participant's space. So that actually presents a bit of a problem, that sometimes they don't have private spaces in their homes. And we've had a few people actually drive to a forest or a parking lot and actually do an entire program through their iPhone.
Isn't that interesting? I heard you say it increased outreach, so we were able to allow others who may have not been able to come in person. But what you just mentioned right now, sounds like virtual care is here to stay, and we can only reap the benefits to come. I'd love to definitely have you answer one more question, and then we're going to lead into our break. So, one of our attendees asked the question, as a healthcare provider, how do you communicate the use of physiological interventions like mindfulness or perhaps meditation or prayer to a patient or client that sees their pain as a largely physical problem?
Right. Well, I think in the early days, 20 years ago, that was the prime thing we had to do at class one. And some people wanted to do an orientation session, but we just put them into class one. And we started to show them the connection between mind and body by doing the supermarket exercise where they're behind somebody in the 1 to 8 aisle who's got like 15 items and their pain is already not very good. And they knew from that example that their pain would exacerbate as their temper flared or their feelings, their suppressed feelings of annoyance would ramp up. And that was actually one of the classic places where people went, aha, okay, now I understand. And then gradually through the program, they would become more and more insightful as to when situations occurred, like putting their house on the market would suddenly put their pain on a different level on a consistent basis until that house was sold. Various things became apparent to them as they went through the mindfulness practice. But yes, I mean, I think it's fairly easy nowadays to show people that there is a huge mind-body connection. I'm going to just go back to one of the downsides of being able to offer mindfulness across long distances, like we were doing in Ontario, is that now our Ontario government, Ministry of Health, has restricted us to offering it to patients virtually as long as we see them in person once every 24 months. So if I have a patient in Wawa, for example, and I'm in Toronto, it's going to restrict if I can even work with them. So there's been some restrictions that are really designed to prevent the uprising of walk-in clinics that will negate payment for doctors who are in the non-OHIP practices and so on. It's to restrict abuse. But that's also restricting us in offering programs to those who we can never really meet. Okay, that's my platform at the moment, is trying to get that changed.
Well, and moving towards that not-for-profit, that advocacy role, I think is going to be especially important. So thank you for sharing some of the challenges we're facing. And I don't want to minimize what you just said, but I know a lot of our speakers and presenters today have talked about that creativeness and creating space. So I wish the best for that. That sounds like a barrier. And I know your strength and your courage and your perseverance will be very, very helpful in Ontario and Canada-wide. So thank you again for joining us today. We're really appreciative. And thanks for providing your information too, because a lot of folks were curious about your email and being able to connect. So you may have a few emails coming your way.
Yes, I expect that. That's fine. Thank you, Christelle. Thanks again for having me.